Sarcoidosis. Sarcoidosis derives from the Greek words, sarko, meaning flesh, eidos, meaning like, and osis, meaning condition. The first case was described in 1877 by Drive. Jonathan Hutchinson at King's College Hospital, London. It is a systemic inflammatory disorder characterized by non-casseting granulomas that classically involve the lungs, but can affect any organ. Since there is no specific test for sarcoidosis, the diagnosis is established when the following criteria are met. A consistent clinical and radiographic presentation. Histologic evidence of non-casseting epithelioid granulomas in more than one organ. Exclusion of other granulomatous diseases caused by mycobacterial infection, fungal infection, berylliosis, drugs, and local reactions to tumors or lymphoma. Although diagnosis relies on tissue biopsy, there are certain situations in which a presumptive diagnosis can be made based on clinical and radiographic findings, such as the presence of asymptomatic bilateral hilar adenopathy, Lofgren syndrome, or Herford syndrome. Who is affected by sarcoidosis? Sarcoidosis occurs worldwide but most frequently among African Americans and Northern Europeans, and it affects slightly more women than men. It typically appears in the third or fourth decade of life, with a second peak in the sixth decade, especially among women. There is a higher prevalence of disease in first-generation relatives of those with sarcoidosis. Obesity may be associated with a higher risk of sarcoidosis. The disease is less likely to occur in people who smoke cigarettes. What are the immunopathologic features of sarcoidosis? The defining pathologic feature of sarcoidosis is non-casseting granulomas, and any tissue may become involved. The major hypothesis of the ACCESS, a case-control etiologic study of sarcoidosis, investigators was that sarcoidosis occurs in genetically susceptible individuals through alteration in immune response after exposure to an environmental, occupational, or infectious agent. Because the lungs are involved in 95% of those affected, it is likely that initial exposure to an inciting environmental or infectious agent is via the pulmonary route. Although the specific antigens responsible for sarcoidosis are unknown, it is generally accepted that this disease occurs in response to antigen-driven activation of macrophages and T lymphocytes. Genetic factors play a role in the racial and ethnic variations in prevalence, clinical presentations, and severity of sarcoidosis. Human leukocyte antigen class II molecules on antigen-presenting cells type II alveolar epithelial cells, macrophages, dendritic cells present the antigen to CD4 plus T helper Th1 lymphocytes. This results in an amplified immune response with increased secretion of Th1 cytokines including interferon gamma, IFN gamma, interleukin IL-2, and TNF, increased tissue permeability, and cell migration. Additionally, there is dysfunctional regulatory T-cell TREG responses and expansion of IL-17 and IFN gamma producing Th17 cells. Ultimately, there is clonal expansion of CD4 plus T lymphocytes in response to the antigens resulting in persistent inflammation, non-casseting granuloma formation, and potential fibrosis of involved organs. In early and active disease, the bronchoalveolar lavage valve fluid reveals an elevated lymphocyte count and a marked increase in CD4, CD8 T lymphocyte ratio greater than 3.5. Additionally, there is an influx of T helper cells and elevated ratio of CD4, CD8 T cell subsets in other affected organs, hyperactivity of B cells, and circulation of immune complexes. Typical clinical observations related to these immunologic events include peripheral lymphopenia, due to sequestration at the site of inflammation, a low CD4-CD8 T cell ratio in peripheral blood, cutaneous anergy, polyclonal gammopathy, 30%–80%, and autoantibody production, low titer rheumatoid factor and/or antinuclear antibody in approximately one-third of patients. What is the typical clinical presentation of sarcoidosis? The clinical spectrum is protean, ranging from an abnormal chest radiograph in an asymptomatic individual to severe multi-organ involvement. Multiple large series report that approximately 95% of patients will present with intrathoracic involvement, an abnormal chest radiograph revealing hilar adenopathy, pulmonary infiltrates, or both. 50% have extrathoracic involvement, and only 2% have isolated extrathoracic sarcoidosis. Despite frequent intrathoracic involvement, less than half of patients present with respiratory symptoms. After pulmonary involvement, the next most common features on presentation are skin rash and ophthalmologic involvement. Notably, there are significant differences in clinical findings, incidence of organ involvement, and mortality between groups on the basis of race and ethnicity, sex, and age. Furthermore, because sarcoidosis is often asymptomatic, the reported prevalence of the disease and organ involvement is likely underestimated. Describe the respiratory tract manifestations of sarcoidosis. The entire respiratory tract from sinuses to lungs can be involved. The clinical spectrum ranges from asymptomatic hilar adenopathy, 50%, to interstitial lung disease with alveolitis. Pleural effusions are rare, less than 5%. Pulmonary hypertension is increasingly recognized, up to 20%, and is likely a result of multiple contributing factors. Symptoms of pulmonary involvement include dry cough 30%, dyspnea 30%, and chest pain 15%. Pulmonary rales are heard in only 20%. Wheezing can occur when there is endobronchial involvement. Hemoptysis and clubbing are rare. Describe the chest radiographic stages of sarcoidosis and their prognosis. For chest radiographs, the scanning staging system is used. Notably, the stages are not chronologic, do not indicate disease chronicity, and do not correlate with pulmonary function testing. High-resolution computed tomography of the chest can show abnormalities when chest radiographs are normal. The chest radiographic stage at presentation can be used to predict the probability of future spontaneous remission, which can help guide therapy. What are the extrathoracic clinical manifestations of sarcoidosis? The most common extrathoracic manifestations are cutaneous and ocular involvement. Skin rash occurs in up to 33% of patients and may be manifest as erythema nodosum in acute sarcoidosis or as subcutaneous nodules, papules, plaques, tattoo, scar sarcoidosis, and lupus pernio in chronic disease. Eye involvement 25%–50%. Is frequently bilateral and can be the initial manifestation or occur anytime during the disease. Any area of the eye may be involved, but anterior uveitis is the most common. Since uveitis can be subclinical, all patients with sarcoidosis should undergo a baseline slit lamp examination. Sarcoidosis of the lacrimal glands is also common, causing eye dryness and keratoconjunctivitis. Granulomatous involvement of the orbit can present as proptosis. Arthralgias are present in the majority of patients, but inflammatory arthritis occurs in up to 25% and is classified as acute or chronic. The acute form is more common and often occurs with Lofgren syndrome. The arthritis is usually oligoarticular or polyarticular involving large joints, with the ankles being most common. The joint swelling may be due to a periarthritis rather than true synovitis. Osseous sarcoidosis is found in up to 13% but is frequently asymptomatic. There is a predilection for the phalanges of the hands and feet, but any bone can be affected. The incidence of skeletal muscle involvement is highly variable because most of the patients are asymptomatic. Muscle involvement with non-casseting granulomas on biopsy may be found in 50% to 80% of all patients with sarcoidosis, but symptomatic myositis is only reported in less than 3%. Hepatosplenomegaly 5%-20%, or elevated alkaline phosphatase 20%-30% is a common finding but rarely cause significant organ injury. Bilateral parotid enlargement is seen in approximately 4% and can be associated with xerostomia. Neurologic findings are observed in 5% and may be the presenting manifestation of sarcoidosis. Unilateral facial nerve palsy is most common, but any region of the brain and spinal cord can be involved. Encephalopathy, mass lesions, aseptic meningitis, peripheral neuropathy, and small fiber neuropathy can also occur. Heart involvement approximately 5% due to granulomatous inflammation of the myocardium and/or the conduction system presents with ventricular arrhythmias, conduction abnormalities, and heart failure. However, many patients are asymptomatic. Up to 25% of patients with sarcoidosis have evidence of cardiac involvement on autopsy. Isolated sarcoidosis affecting the heart has been reported. Hematologic manifestations include anemia and leukopenia. Anemia of chronic disease is most common, but bone marrow involvement may be found in up to 27% of anemic patients. Leukopenia may be due to sequestration of lymphocytes to sites of inflammation or hypersplenism. The hypothalamic pituitary axis may be involved and classically presents as diabetes insipidus. Kidney and gastrointestinal organs are rarely affected. Vasculitis of any size vessel has been described. Fatigue is common, over 50%, and can be disabling. Thank you.